Yeah. I received so many emails. Can you hear me at home? What to study in LGD. I mean, LGD is a way of getting together the four disciplines or the three disciplines: pharmacology, immunology, and microbiology. It's the same we address in the lectures, so nothing really new, except that we give you the chance to understand how you look to a scenario and then some question related to pharmacology, microbiology, immunology, pathology, and so on. But otherwise, it reflects exactly what you have taken in the lecture. So nothing really new. And I was wondering why the student asked me this question. Okay. The other emails, I received so many emails that they need me to what? To send them the answer of the LGD question. I can't, because it's more or less a discussion. You know what I mean? So now feel free, the one at home too, to address or to discuss or to question what if you don't understand anything. Take the chance of what we're doing now, okay? Professor Dilip will start and then we'll open for the discussion from everyone. Please at home, again, some of you complain that they cannot hear, we are not answering their questions, whatever. Please feel free to send any message and then we will look at it now.
At home, are you hearing us? Yeah?
They are?
Good. So please
Yes, Doctor.
interrupt us then and there if you have a question. So we won't move forward without satisfying you or without answering your question. So let's start. We have prepared few cases, integrated cases, and see how the discussion goes.
I think.
Case 1. A 30-year-old woman runs a fast food shop with her husband. Early one Friday morning, while cooking at the shop, some hot oil spilled on the back of her right hand. Do you want me to read or you can read on your own?
If you want to.
Okay. As Friday is one of their busiest days, she could not afford to take time off work. Therefore, she applied some dressing and took a painkiller. She just managed to cope at the shop and decided to visit hospital in the evening. By this time, the hand was swollen and the skin had peeled off. Everything clear? Any word which is not understood? Good. On examination, the doctor found that she had burns affecting the dorsal aspect of the right hand. The affected area was yellow and dry with a leathery consistency. A few blisters were also seen. He cleansed the area with a disinfectant and applied topical dressings with silver sulfadiazine. He also asked her to come back daily to change the dressings. She was given a prescription for analgesics and asked to take a few days off work. Now the question is, can you describe the immunopathological events which occur following severe burns to the skin? Answer. Garvin.
So anyone, first of all, she's got a raised temperature on her skin, and then suddenly she's got inflammation. So how would you describe this, just in general terms? Sterile inflammation as opposed to an infectious inflammation, right? So can you recall the sequence of events when you're getting boiling water or boiling oil on the skin, and soon after that you're feeling pain, swelling, redness, all of the normal manifestations of inflammation? What are the events, immunologically speaking, that result in this pathological process? starting with the epidermal cells in your skin.
Anyone want to answer from home?
Is there any reply from the
Anyone want to answer from home?
No? Okay, you explain then.
All right,
Yes,
so you're getting this 100-degree heat on these cells.
Yeah. What is that?
Maybe she wants to answer. She's raised her hand.
could they hear me?
She answered here.
Sama Alotab, you have the floor. You raised your hand.
Yes, she can unmute herself.
Sorry?
She should unmute herself.
Yes, doctor.
I think the mute button is active for all the participants.
not.
on it.
No, it's going to be.
It's the system. It's not receiving.
Is not?
It's not working. Yes, doctor.
To have feedback.
I know.
Today it's not working.
Yeah, I can't hear them. Even though the volume is on.
Oh, okay. Sorry, Salama. Can you
Maybe she can type it into
can
the
you
chat,
type your answer?
into the chat box and then we read it out.
Okay, go on.
All right. So you get damaged cells. So these cells get damaged. They burst. What follows after that? So the intracellular contents of the cells are released, and these intracellular contents like DNA, mitochondria, heat shock proteins, they get picked up by what sensors on nearby cells like dendritic cells, macrophages. What are these receptors called?
There are a few responses. It begins with them.
We're talking, you can't hear us. Yeah. All right. So it begins with DAMPs. Very good. So DAMP stands for damage associated molecular patterns. So these intracellular contents, the DAMPs, are released. They get picked up by the PRRs. What types of PRRs do you know about? Toll-like receptors, knot-like receptors, rig-like receptors. These get taken into the cells. There they get recognized by the intracellular PRRs like knot-like receptors. If it's a knot-like receptor, that will coalesce to form a structure which we call the inflammasome. The function of the inflammasome is to do what?
So there are a lot of answers here.
Yeah.
Activate.
All right. So the activity of the inflammasome is to create an active IL-1 and IL-18, which then gets secreted to stimulate the inflammatory response and produce all the normal manifestations of inflammation. Very good. Okay.
Following damage to the tissue, what cytokines would be made for wound healing?
So there are two major cytokines, or one major cytokine is IL-10, yep. Sorry? TGF beta. Very good.
Also recognize these students. Al-Hanouf,
Yeah.
they are responding.
TGF beta, yep. Good.
Okay, what is silver sulfadiazine? Anti-metabolite. Which belong to group of antibiotics does it belong to? Sulfonamide. Why it is used in burns? The only indication of silver sulfadiazine is it is not used systemically. It is used topically, and only indication for its use is burn, to prevent burn infections, because it binds avidly with the damaged skin and stays there for prolonged periods of time. So this is a drug of choice among all the drugs, which is used topically to prevent burn infections. What analgesics she was given and how do they work? Ibuprofen, okay. Only ibuprofen? Aspirin, okay. Aspirin, ibuprofen. Is there any difference between aspirin and ibuprofen? Is reversible and ibuprofen. How do they work? COX, which COX? Both, non-selective COX1 and COX2. So with the inhibition of COX, what will happen? Side effects. So Lean, Ahmad Juwaidi, Iman Ejaz, Noor Hamid, they responded properly. So with the inhibition of COX, there will be, so inhibition of prostaglandin will lead to
Desensitize the neural switch for histamine and bradykinin, which decrease the pain sensation.
histamine and bradykinin. What do they have relationship with prostaglandin? Histamine and bradykinin.
Prostaglandin is BTE2. It sensitizes the nerve endings for histamine and bradykinin.
Okay.
So in the inflammation response, we know there's a release of both
Okay.
bradykinin and histamine, which cause the pain.
Okay. So which prostaglandin specifically?
PTE2.
PGE2. And what will happen to other prostaglandins?
Also,
So
not selective, it will
that will be responsible for causing some side effects, which we will discuss later on. Good, very good. So you have proper concepts about analgesics. Over the next few days, the intensity of the pain had increased, and her right armpit was a little tender. She was feverish and felt quite unwell. While changing the dressing, the doctor examined and found that she was febrile with a temperature of 38 degrees Celsius. On inspection, small amount of yellowish discharge was seen over the burn with swollen and reddened surrounding area. Palpation of the axilla revealed swollen, tender lymph nodes. Is there any difference between this picture and the previous picture? What is the difference? It is? Yes, please. So now, was it the infection or simple injury previously? Now, it is infected now.
So can I just step in? This yellowish discharge, what do you think that is?
We have a question on this.
Okay, cool.
What is the significance of increased intensity of pain and fever now, as you mentioned right now? Now it is infected.
Okay, so the yellowish discharge is pus, and that originates from dead neutrophils.
Yeah, very quick,
good.
very quick.
I know. I'm proud of you, my children. So, and these this discharge from these neutrophils, we call them what? NETs, which stands for nuclear extracellular traps, right? So a lot of those are the DNA from the neutrophils, which is viscous. So one of their properties is to trap the bacteria. But the other function also of these nets is that they also act as what we call alarmins, because just like the MAMPs, they are also picked up by PRRs to aggravate this inflammatory response.
So here's a question.
Epson, no. Sama, I don't understand. There isn't such a word.
She may be meaning opponents.
Not so much obstinance, no. Because obstinance, what would be involved with obstinance? Sorry? Right, phagocytosis. But what are the two mediators of obstinance? What are the two obstinants? Complement, yep, and antibodies. So yeah, so you can get opsonization in this case too. Very good, because complement is activated as soon as you get this the microbial infections. If there are existing antibodies in this person, those antibodies can bind to the bacterial cells and then activate the complement through what pathway? Sorry? Classical pathway. Very good. Okay.
Okay, Mohammed, what are the possible sources of infection in this case? Where did the bacteria come from? From the skin?
What we call it is from the skin. It can be
Exogenous, okay.
There's a question. Why was she feverish and there's pain? Shouldn't the NSAID she was taking block it?
That's the lips.
Yes, okay. Someone asked, the question has gone upward now, that why she was taking, having fever and pain. Of course, it is not all or none process that you take the analgesic and antibiotic, the fever will be gone forever. As long as she is having infection and you are not treating with a specific antibiotic, then the fever will come and go again and again. In spite of the fact that you are taking antibiotic, it will decrease the intensity and frequency of episodes of fever, but it will not treat or cure the fever forever unless you are taking specific antibiotics to cure the infection. I hope it clarifies. Okay. Good.
So what was the answer? What are the possible sources of the infection? Very good. So endogenous means what? And exogenous? So in this case, where is the exogenous source likely to be from? Where? You said exogenous. No. I'm asking for the exogenous source. Which environment? What did she do when she initially sustained the burns? She dressed it. Then she did what? She went to the doctor, right? So she could also have something from the hospital, from the dressing, from her normal microbiota. So that's good. Yes, somebody said it's from the hospital.
Okay. Can members of the normal microbiota cause infection? It was answered already.
So what will you call this? Endogenous and opportunistic, because now she has bonds. Okay, very good. Opportunistic.
Okay.
So, considering that we've got pus-forming bacteria, what kind of immune cells would you expect? Neutrophils mainly, yeah. Macrophages. Uh-huh. So we've got macrophage, neutrophils. So this is the immediate natural killer cells. Yep. So this is the immediate response. A couple of days after that, what kind of cells would you get? Dendritic cells. So the function of the dendritic cells would be antigen presentation, and then you get the influx of lymphocytes. What kind of lymphocytes? Cytotoxic T cells. Th17, yes. Th17's function is to do what? Attract neutrophils through the production of, and the other subset, well, that is the cytokine that Th17 produces, but the other T helper cell subset that you would expect in this, sorry, Th1 cells, which the major cytokine for Th1 cells being interferon gamma. So now someone was asking, what about So what does IL-TH17 produce? It produces IL-17, which is its main function is to attract neutrophils. So that increases the phagocytic response. Why cytotoxic T cells? Because cytotoxic T cells, even though you learned that they are predominantly against intracellular antigens, but cytotoxic T cells can also act against bacterial cells to kill them. Someone said M2 cells, would you expect M2 cells at this stage? No. Because remember that M2 cells are mainly anti-inflammatory, so they would be seen more at the end of the response, because the major cytokines of M2 cells would be IL-10 and TGF-beta in terms of repairing and wound healing. So yes, you would expect more M1 inflammatory type macrophages. Very good. TH2, would you expect TH2 cells? No, not at this stage. Very good.
So Garvan was actually responding to the questions here. Okay, this is
They can see the question, the responses.
Yes, yes, yes.
Yeah.
they are
Yeah.
here. Okay, good.
So what are nets and how do they contribute to this inflammatory? We've already covered this.
Covered?
Yeah.
The doctor took a swab from the wound and sent it to the microbiology lab for culture and sensitivity. He explained that the result would not be available for a few days, but he started her on co-emoxy injection right away after a test dose. Anything that needs explanation? No? What is co-emoxy? Augmentin is a trade name. Tell me the composition of co-emoxy. So amoxicillin plus clavulanic acid. What is clavulanic acid? Why has it been given? Does it have some antibacterial activity of its own? But why was it given along with amoxicillin? So if you are suspecting some beta-lactamase producing bacteria, so that combination has been given to prevent the resistance which might have occurred due to beta-lactamase against penicillin. Okay, we already got responses, several responses. Why did the doctor decide to start antibiotics without waiting for the lab result? Empirical treatment. So what is the purpose of empirical treatment? Yes. So because of infection is progressive, and in the previous stem we saw that the result will be available after 2 to 3 days. By that time you can't wait for the result to come and then start antibiotics. So what is the difference between this empirical treatment and the treatment which you administer after receiving the causative report on the causative organism? What is the definitive treatment, and this is the empirical treatment? What helps you to decide about empirical treatment? Symptoms are the same. Pain, fever, inflammation, everywhere. Source of infection. Coverage of antibiotic you will decide later, but keeping in mind, there are certain factors which help you to determine the most probable causative organism in this situation. And the factors are, first of all, the age, the circumstances under which the infection has happened, okay, the type of infection, the area which has been affected, and the epidemiological data, previous data, that in this type of infection, what is the most possible cause of infection. So this epidemiological data, this is all your subjective judgment, but that subjective judgment is based upon some objective data. okay, which you have, and then you decide about the empirical treatment. In most situations, it is okay, but sometimes it is proved to be wrong. So you have to wait for the definitive treatment. So that is why sometimes empirical treatment covers so many organisms at the same time, large spectrum. And after receiving the culture report, you go to narrow spectrum antibiotics. Okay. So presentation of patient based on previous data of science, okay, very good. Etiology, the type of fever, yes, type of fever. How the type of fever is different, it will make you lean. Can you hear me? Lean al-Oteb? You have mentioned the type of fever will judge you. How? Can you explain it? Okay, let's move. Within minutes after injection, the patient reported itching all over the body, dizziness, and profuse sweating. She also complained of nausea, abdominal cramping, and difficulty in breathing. On examination, she was confused, looked pale, and her extremities were cold. Blood pressure was 80 or 45 millimeters of mercury. Pulse rate was 100, and respiratory rate was 22 per minute. Are you figuring out what is happening? Hmm? Okay, people are writing here. Many students are writing Al Hanuf and others say septic shock. No, it is not septic shock. It is anaphylaxis shock. Because this has happened after injection of coamoxicillin. What is the interpretation of the symptoms after injection of this is so many students have gone for septic shock. Please correct your concept. This is not septic shock. This is most probably anaphylactic shock, and the feature is that it has happened immediately after injection of penicillin, coamoxicillin, and coamoxicillin, penicillin is very notorious of causing anaphylactic shock. Okay. What is the basis for penicillin, amoxicillin hypersensitivity? Type 1. Is it protein? Is it?
Sorry, if it's type 1, what type of antibody would you expect? IgE, right? So what, again, follow the steps. So you got IgE. What will happen then? So the IgE binds and you have release of histamine. Why do you get degranulation from mast cells? Because the IgE binds and cross-links the receptors on the mast cells for IgE and so on. And now in terms of the antigen, so you got penicillin there, which normally isn't antigenic, but in this case is causing this type 1 hypersensitivity. What do we call this type of complex?
Mm-hmm.
No. So the penicillin gets in, heptin.
Someone is
What do we call it? So and haptin carrier, right? It forms a haptin carrier complex. So what is the definition of a haptin? It's antigenic but not immunogenic, right? So antibodies can bind to it, but it's too small to induce an antibody response. So in order for it to become immunogenic, it needs to be bound to a carrier. Very good. Okay.
Doctor ordered the nurse to raise foot end of the patient. An IV line was secured with rapid infusion of IV fluids, obviously IV fluids, to raise the blood pressure. What drug is required to manage the situation, and how will they act? tell us only one drug, epinephrine. Can you explain why epinephrine? There are several answers. Okay, epinephrine. Why epinephrine? Epinephrine in this situation would be termed as a physiological antagonist to anaphylaxis.